Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on 1st and 3rd Friday of every month from 3 p.m. onwards. The NAMS-AIIMS PGIMER CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medico CME is to help them to be more proficient in their profession. Each session will cover 1 or 2 topics followed by questions and answers. Thank you for your kind support.
Hello and good afternoon, everyone, to the next session of AIIMS, NAMS, PGIMER, Navigate Medico CME program. So in this series, today we are with very interesting and very important topic. Since we all witnessed and it was taught during the series and also during the introductory lecture by Professor Kharbanda sir, that prevalence of cleft lip and palate is very high, and as per the latest journal that I went through, it is around 1 in 500 to 700 newborns. And also, like, apart from congenital, it is also observed developmental issue. So if we connect cleft palate and cleft lips to other issues, then the malocclusion is very common. Around 80% of the patients, they do have comorbid malocclusions, and also leading to facial deformities. Now the deformities, they have huge impact on facial appearance, then the functionality and many other domains of life. So considering the importance of topic, and today we are privileged and honored to have sir with us.
Thank you.
So just to begin with the session, and again, the most important thing in today's lecture is that it is focusing on 3D digital tools and in diagnosis and treatment, and that would be very interesting to know about it. So just to begin with the session, I would like to request Professor A.K. Sood sir for the welcome address. Sir is Deputy Secretary of National Academy of Medical Sciences. Over to you, sir.
Thank you, Dr. Jaswant. Again, it is my great privilege and pleasure to welcome the distinguished speaker for this session, Professor O.P. Kharbanda sir. Sir is our senior council member, NAMS Emeritus Professor, and former Chief of the Center for Dental Education and Research, AIIMS. And sir has also kindly agreed to be the Chief Coordinator for this series on oral health. So welcome, sir. And I'm sure that the practical tips which you are going to give to all of us, especially to our PG student in the area of cleft lip, cleft palate, and malocclusion and facial deformity, especially, as Dr. Jaswant said, use of the 3D technology in diagnosis and management. I think it is one of the latest technology which sir is going to share his experience with all of us. So we are welcoming you, sir. And I also take this opportunity to welcome all the participants, the faculty members from various dental institutions, medical colleges, and postgraduate students. So it is your own program. And if you have any question, your remarks, please put the question and remarks in the chat box. Sir will be happy to answer. So once again, I extend a warm welcome to all of you. And I'm very sure that very productive discussion we'll have in this session. Over to you, Dr. Jaswant.
Thank you, sir. So now I request the technical team to please have a message from President, National Academy of Medical Sciences, Dr. Digambar Behra, for all of us.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The government of India has recognized the academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the norms. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you for the message. Now I request for the message from Professor M. Srinivas, the Director of All India Institute of Medical Sciences, New Delhi, for the message. Thank you.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high-quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you for the message. So now it's time to introduce, and again, it's our privilege and honor to introduce the speaker for the day, Professor O.P. Kharbanda sir. Sir has also been the chief coordinator of this series on dental and oral health. And today, sir will be taking this session. Sir is currently serving as director of orthodontics and cleft care center. Sir is also professor emeritus and council member at National Academy of Medical Sciences. And sir also served as professor in chief at CDR AIIMS and also CMET AIIMS. Sir is highly decorated with prestigious awards and is author of multiple new publications and books. So without wasting time, and I won't take much time, sir is already a renowned personality. So now I request sir for the wonderful session, sir. Sir, thank you, sir, for coming, and over to you, sir.
Yeah, trying to share. Am I visible and okay? Okay? Everything is okay? Share नहीं हुआ? फिर तो हो गया ना? जी सर. इसको मैं मिनिमाइज कर सकता हूँ. Good afternoon, the esteemed audience from across the country. On my left is my colleague, Dr. Sood, and on my right is Dr. Jan. And also, I like to thank the National Academy of Medical Sciences, particularly Dr. Behra, the president, and the executive, to having allowed me to coordinate this series. This thought came after some discussion with the president and the secretary, and then they accepted the request. And I think it is going to be the very unique series because this, for the first time, we have covered oral health and dental diseases in National Academy of Medical Sciences. We have very carefully chosen the topic to cover the entire breadth of dentistry, and which is obviously not possible in a small number of lectures, but nevertheless, we are trying to fill Gagar mein Sagar. We are trying to give you as much as possible in this condensed form. And I will try to do my best efforts today to give you information on birth defects, particularly related to face, cleft lip and palate, particularly non-syndromic cleft lip and palate, and some aspects of facial deformations and the 3D planning. So thank you very much for your introduction, sir. And if you want to know more about it, you can scan this this thing, and I am available on a website as well. I will be sharing you a lot of experience which I have done in the past, more than 4 decades, working with the All India Institute of Medical Sciences, where we started a small dental department into a big center for dental education. I worked with ICMR and still continue to work with it. I also founded the Cochrane Oral Health at CDR and worked with WHO and many other organizations. So this experience gained from these resources and these eminent institutions will be shared with you. When a baby with cleft is born, multitude of issues come up. These issues are social, these issues are financial, these issues are ethical, and even medical issues. So the components of problem is very long, from psychology to feeding, the primary surgery, hearing and speech, dental and oral health, oronasal fistula, sleep disordered breathing, residual surgical defects, abnormal growth of face, facial defects, missing teeth, extra teeth, nasal deformities, mutilated dentition, no occlusion, social issues, matrimony, and much more. So this is only a small list. It is not complete by itself. And therefore, the treatment of cleft child starts now even before birth, because it is now possible for us to see through the ultrasound if there is a cleft defect, and counseling can start from there. The treatment goes to the next generation because the cleft children are likely to have babies with cleft because of the its inheritance pattern, in addition to the other reasons of cleft etiology. So there are so many other invisible components of the cleft care, and one of the invisible component most significant would be psychological illness of a cleft child. A child with cleft, although he has been treated, undergoes significant trauma of surgery. Sometimes there are difficulties within the family, leading to broken families. And most cleft children would have some or the other kind of psychological issues which may be hidden and not that obvious. Quite often, they are introvert and they have social issues. The high cost of treatment and multiple specialists required to treat may be unaffordable for many. Therefore, where the social system is not there, many children remain untreated, half-treated, or improperly treated. In addition to that, since it requires a long years of treatment, the total burden of care is huge because the parents have to miss the missing hours. So there will be missing hours from school, missing hours from work. So the total burden will be very, very high. So each of the cleft child has an handicap. He has a communication handicap because he cannot speak well. He has malocclusion. He has poor aesthetics. And because of speech and poor aesthetics and poor communication, he has a psychological handicap. His respiration is often abnormal. Quite a few cleft children suffer from obstructive sleep apnea, and difficulty in mastication altogether lead to a handicap in different ways. I will request you not to take picture of the children. However, it is okay if you want to take or record the text. Therefore, my request is to please avoid taking any pictures in any form. So when you have a cleft child like this who is treated so well, as you can see the girl on the left, you want that every child should become like that. And this is one of the few patients treated by me who have become so happy and so beautiful, not all. So this is the aim, but to attain this aim, it is not easy, because now this particular chart will give you a protocol of the treatment. So when the child is born, very often we like to give him a NAM appliance or feeding appliance, followed by primary surgery, which usually happens at 3 months or 4 months now. The palate repair, which is the primary palate repair, is done around 1 year to 18 months of age. Quite often, these patients would have hearing problems, speech issues, and they need treatment for speech therapy as well as treatment for the middle ear infections. These kids will receive bone graft anything between 8 years to 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 11 years or something like that, and followed by orthodontic treatment, which usually goes from 6 years till adulthood. Subsequently, most of these children would require some kind of rhinoplasty, revision of the lip, and many of the patients require orthognathic surgery. If you wish to know more about it, probably you can look into this website down, which will take you to the my book on cleft palate, give you more detail. They require psychological support all through life, and their oral and dental care is needed since their baby teeth erupt. Now the concept of cleft care has gone up to pre-birth. As you can see, I have added another box on the top, which means that before a cleft child is born, if detected on ultrasound, the counseling of the parents start from that time onward. It is quite obvious that cleft would require an interdisciplinary care. And in India, because of the high prevalence, it means we get about 35 to 40,000 new cleft babies every year. And since they require very, very long treatment, so the cleft center at the moment are very few where we provide the comprehensive planning, comprehensive treatment. Quite a few centers are doing surgery, rather many centers are doing surgery, but the comprehensive treatment would include speech therapy, ENT care, dental and orthodontic care, and subsequently rehabilitation of the mutilated dentition. So the cleft can present in many forms. These are just the few variations which are seen in this picture. It may be in a micro form like the cleft of the lip. As you can see that, it may be only limited to the lip on one side or both the sides. It may extend into alveolus called cleft lip and alveolus, and when extending deep into the palate, it becomes UCLP or unilateral cleft lip and palate. And when it is on both sides, we call it bilateral cleft lip and palate. It can be limited only to the hard and soft palate, or only to the uvula, or sometimes in microforms. So there are huge number of classifications given in the books, and sometimes they were confusing, but we like to limit ourselves with a very simple terms: cleft lip and alveolus, unilateral cleft lip or BCLP, cleft palate or isolated cleft palate. So in general, these clefts can be grouped into two broader categories, which are the cleft of the palate and cleft of the lip and palate, because of their different etiological process, more so on the genetics. So if you see a child only with cleft palate, it may appear that he has a small defect, but the chances of its having other systemic conditions, particularly cardiac and the renal, are much more. So the cleft palate child in a group may be 50% may be syndromic and 50% non-syndromic. However, if you go to the cleft lip and palate, the chances of having a baby with another problems is only 5 to 10%. So a huge number of children would be non-syndromic. So we will be focusing ourselves today to the management of non-syndromic clefts, and syndromic clefts can be taken up at some other time. You can also have the facial clefts extending into the face, extending up to the orbit and cranium. And these are usually classified according to the Tessier classification, which will be a little bit beyond the scope of this lecture. So I will focus myself to this simple terminology and classification of cleft lip, lip and alveolus, lip and palate. If it is one side UCLP, both side BCLP, isolated cleft palate only, and submucous cleft. The UCLP is the commonest. The BCLP comes on the third. However, the BCLP is more complex to treat. So this is, therefore, most research which you will find studies will be focusing only on UCLP because of their high number. And also UCLP is more common in females than males and then females, and more on the left side. Regions are still being researched, but we know that these facts we know. So we all have studied as students that during the 8th week of intrauterine life, the face starts forming like small pieces of Legos. They come together and make the face, different processes. And when there is union of these processes does not occur, the cleft occurs. So depending upon which process does not fuse with what process will be the type of cleft. So if the maxillary palatal halves do not fuse together, then it leads to the cleft of the palate. And when mid-nasal and maxillary do not fuse, they become cleft of the lip and palate. However, one has to understand very clearly that the fusion occurs from anterior to posterior direction. And there is a process, a very significant process of EMT, which is called ectodermal
It's
mesenchymal
3:30.
transformation. Am I audible? Everything is okay? Any response from okay. So they come together, they fuse together both palatal halves, tongue goes down, and the palatal fusion occurs. In females, the fusion occurs a bit late. Therefore, the chances of having cleft palate in females is much more. This is just to give you an overview that how different type of cleft palate can occur. Now, this is a bit of an important slide to understand that during the intrauterine life, after the fertilization, during the fetal development, during the first few weeks are very critical. And these weeks are critical because the facial structures and fusion occurs during this time. Any insult during this time due to alcohol, smoking, or other reasons would influence the facial development, which will fall under the group of epigenetic factors, and there may be already some genetic factors. So genetic factors inserted with epigenetic factors will lead to formation of cleft. Now, once a baby with cleft is born, if you look at this one here, the yellow outer circle, he already has a defect. And now it is up to us as doctors, as healthcare workers, to provide him a treatment which will give him the optimum outcome. And if at this stage, we do not provide him enough nutrition, we do not provide him surgery in time, we do not follow a good protocol for the treatment, we will leave him to a situation where the outcome may be compromised. Therefore, adult treatment outcome at the level of adult will depend upon both epigenetic factors, which will decide the severity of cleft, genetic factors, which again decide the transmission of cleft, and the environmental factor after birth, including the treatment to give this outcome. So quite often, you have seen the first child as an adult fully treated, but we get this kind of a spectrum, which is very, very half treated, fully treated, partially treated. This is not the situation which is worth showing actually, but that is the fact. That is what the fact it is. So we have to treat these patients much late because they have not followed the protocol of primary surgery, lip surgery, and palate surgery. And I'll be sharing you some of the cases which we have treated, these referred cases from different parts of the country. Here, I just like to give you an overview of congenital anomalies of craniofacial region, which are about 2 to 3% of the overall anomalies. And unfortunately, it is the poor country and malnourished children who are getting affected much more than this. So in India, we have about 35 to 40,000 new cases. But the issue is that sometimes their primary surgery, which has been more or less now taken over by the NGOs, does happen. a very few patients can afford to the public hospital, but other cares like ENT, dental, orthodontic is not available to all. And you have seen that you have this spin spectrum before. So in India, how the cleft is being tackled? Under the RBSK, which is the Rashtriya Bal Chikitsa Karyakram, the cleft is included as one of the anomalies which needs to be detected. I had an opportunity to serve RBSK as a co-chair many years ago when the cleft was being, when the RBSK scheme was being created and it was being formulated. So we were fortunate that we could include at least few things from oral dental point of view, the cleft, dental caries and hearing impairment. So each cleft child is now, when born, is detected, is sent, registered and sent for the surgery. So primary surgery is very often done, but the problem in the cleft starts after primary surgery because maxilla stops growing, and that child needs lot of other things which are still under consideration in many parts, including India. So unlike in European countries, which are the social countries, particularly Scandinavians, if a cleft child is born, the government takes care of all aspects of its care, including travel of parents. They are different level of healthcare system than our country. So this particular flow chart will give you how counseling is required by the pediatrician, psychologist, and at birth how nurse become important because she's the one who will support the breathing. The role of orthodontist is very small at this stage, but nevertheless, it's always a good idea to introduce an orthodontist to the team because he's the one who is going to prepare the first feeding appliance once the child is born. And at that stage, like in this case, when there is this baby with UCLP, complete UCLP, now we like to scan the mouth using a scanner. And after scanning, we create a facial and the intraoral scan. And on this scan, we prepare a feeding appliance, which is called nasoalveolar molding appliance. And the idea of giving this appliance is to provide a support which will allow these bony fragments to go together, shorten the gap, and raise the dome of the lip. So a baby like this, when given an feeding appliance, is facilitated on breathing, is facilitated on feeding, which helps him to take weight gain, and the weight gain and prevention of chest infection is critical for the baby's fitness to undergo surgery at 3 months or 4 months. So this is very, very critical. So earlier we used to take impression with alginate impression or rubber base, and there was a high risk of aspiration or dislodgement of the impression leading to respiratory blockage or even sometimes cyanosis, and it could lead to death also. So it was a highly, highly risky procedure. But with the scan process now, these things have become simpler. And we can 3D print what we scan, we can do 3D print. So in the third image, you will see on the right that the baby has also been provided a nasal stent. So we don't provide nasal stent in the beginning. To begin with, it is only in plate, followed by after a couple of weeks. And this should be done as early as possible after birth, because the modification or the hormone of the cartilage, particularly the cartilage in the nasal dome, is more sensitive because of the presence of certain hormones in the which are transferred from the mother to the small baby, and therefore it is critical that we initiate this very early. And this is another girl who was holding her tongue into the split of the maxilla, and this was not helping her to breathe well. And the moment she is given this appliance, nasoalveolar molding appliance, as you can see that her breathing is facilitated, nose dome is getting better. And now she cannot live without this, because if you take it out, she's uncomfortable. And the most important thing is once the baby starts breathing well, feeding well, he sleeps well. If he sleeps well, he grows well. And that all these factors are important for making the baby fit for surgery, fit for anesthesia at 4 months of age. So these are the benefits of Other things which we like to promote is feeding, feeding training to the mother using either football position or using special bottles like this. So this nasal molding, which I mentioned to you before, can help in many ways in the beginning, but in the long run, we do not know, because most of the trials coming from Dutch trials are showing that the earlier effect of reshaping the premaxilla, lip and nose are lost. But there are other benefits other than aesthetic benefits, which I have mentioned before. They still hold true. For bilateral cleft lip and palate, there are many ways to do it, but we evolved our own technique in which we use the traditional bonnet cup, but we make it with silicone. And as you can see that in few weeks' time, this premaxilla, off-center premaxilla becomes in the center, and then it is possible to do surgery at an appropriate time. It facilitates surgical closure because of there is a lack of tissue, and centering the premaxilla will lead to better lip closure. These are some of those cases. This work is published well in American Cleft Palate Journal. You can reach it there for more details. Sometimes we get a baby like this patient came to very recently, only 2 weeks ago. He reached us from very deep village in Bihar, somewhere in the Jharkhand or Bihar border, and premaxilla is too far forward. And earlier we used to resect this premaxilla, but resection of premaxilla will lead to maxillary hypoplasia. So we like to treat such cases with premaxillary retraction appliance, similar to what I have shown you before. That helps. A lot of research, we are working with 3D scanning on benefits of utility of intraoral scanner. We are adopted IO scanner into extraoral scanner because facial scanners are very, very expensive and not available everywhere. So we have proven this, that it can be used, and it has been calibrated and tested. And this is more of a research value, but for the clinical sense, what I want to convey you is that now we can use 3D devices for the rehabilitation of cleft patients. So during first year, the pediatrician is important. The lip repair, second repair of the palate occurs, and sometimes we need to assess at this stage the hearing. Hearing assessment is important because of the development of speech, and you know that during this year, this time of life, the speech development will occur only if baby is able to hear. And most of the cleft children have issues with the hearing. So hearing needs to be resorted to develop the good speech. Quite often the parents think that because it's a cleft baby, and even medical people think that it is a cleft baby, therefore the speech is delayed. But the speech is not delayed because the speech is delayed. The speech is delayed because the hearing is not happening properly. So these patients would require audiometry, speech testing, sometimes grommets, and all kind of things. And as the child grows early, around 4 to 5 years of age, we need to see that there is no fistula in the palate, there is a mobile lip, velopharyngeal seal is good, that the soft palate coming in close contact with the posterior pharyngeal wall, and we have a good palate. So this picture is trying to explain you how small soft palate will lead to escape of the air from the pharynx, leading to nasality of speech. So any baby with the nasality of speech should be tested for fistula and also for velopharyngeal efficiency or insufficiency. And if needed be, this will require corrective surgery, which requires pharyngoplasty quite often. So by 3 years, the dentist becomes very, very important beside audiometry and the speech. And because these children are likely to develop very severe caries. And they develop caries because the parents think that if they give them normal food, their sutures may break down, the palatal fistula may become bigger. So they give him more sugary drinks and do not brush. So that leads to a high incidence of caries. And once the dental caries settles in, all permanent teeth will erupt into different positions. So that means you are complicating the situation. So dental care at this stage is very critical. And this care should continue into care for speech for next up to the 5 to 6 years of age. And that at 6 years, we have a complete orthodontic examination of the child with plastic surgeon and oral surgeon. And at this stage, we also make full records. And what does a full record in a cleft child means? Complete photographs. Sometimes we use even 3D CT now. Earlier, we used to take a lot of cephalogram, occlusal X-ray, intraoral X-ray. But now some studies have shown that if you can use low radiation CBCT of the limited FOV, which is limited to maxilla and mandible, in that case, your radiation is almost similar to all collective X-rays. And that means if you have a cone beam CT, then with one X-ray, you can have everything possible. You can create a OPG, you can see with great detail. So these patients, if their maxillary teeth are coming in, if they are developing a class 3 kind of a situation, which I will show you how it looks like, then you need to treat them immediately. So for example, in this girl, there was a situation when the maxilla hypoplegia is happening because all cleft will undergo some kind of maxillary contraction, restriction of the maxillary growth and overgrowth of the maxilla, leading to mandibular prognathism. So you treat them as early as possible using simple devices. For example, in this case, she has been treated with a simple orthodontic appliance with jade springs, and crossbite is corrected. We do not try to medialize the dental-velar segment at this stage till the bone grafting is done, because we need to graft the bone into the bony defect. And as you can see in this case, that how beautifully this the correction has taken place. Another case, this is a BCLP again, anterior crossbite, pits in the lip, corrected with crossbite. As you can see that his crossbite is corrected, but we have not corrected the tooth positions. We do that only after bone graft. So he underwent comprehensive orthodontic treatment. As you can see that he's undergoing treatment with, and common man calls them braces. The idea is to align the maxillary teeth, align the teeth in the mandible, give him a normal facial profile and aesthetics, and that is how he is after the treatment. So he is now using a plate, as you will see in this here, which is carrying 2 extra teeth for the missing teeth, because most cleft patients will have either missing lateral incisors or rudimentary lateral incisors. In this case, missing lateral incisors, they have been substituted with a partial denture. So you restore the confidence of the child. You restore the function of the child, and you restore the aesthetics of the baby. Are there any reactions coming from good or bad? Srivastava ji? Are they able to hear? So these are some of the aspects of treatment which we do routinely, and that is what is the rehabilitation of a cleft child. So in this case, you will see that this premaxilla is centralized with orthodontic treatment, and these missing teeth have been replaced with an appliance. And this is a published case as well. You can access this in Journal of Cleft Palate. And this was a case of Vanderwood syndrome. In Vanderwood syndrome, we usually have bilateral cleft lip and palate and the pits on the lips. Another case in which the premaxilla was very prominent and down after the surgery, he reported us at the age of 15 years, delayed eruption of teeth. As you can see, still he has many baby teeth in mouth. So the idea was to intrude the premaxilla here. To intrude means to take it up towards the nose. So we did that very effectively. First, we have to expand the jaw. Here it has been expanded with expander. And after expansion of the jaw, we use the, again, orthodontic appliances or the braces, which a common man calls it. Here you can see in the X-ray that how far down is the premaxilla and how far forward. So we intruded the premaxilla using special techniques, which is called Ricketts intrusion arch. We used, in this case, mostly TMA wires, which are very flexible and produce very low force on the teeth and leading to the correction of the problem, as you can see in the bottom line, bottom row. So these are some of the success stories of the cleft treatment, and we often want to share these success stories to the patients, because when a child with cleft comes to us, he has lost all hopes. He feels that nothing can be done, and he would have to live with this deformity all his life. It is possible to rehabilitate him, not only physically, not only aesthetically, but also psychologically. In my experience, what I have seen, the day they start feeling normal, their behavior, their social interactions, their self-confidence changes. Also, the treating doctor has to work as a counselor sometimes. And sometimes, and in fact, with me, it has happened many times that these children with cleft who have never shared anything with any other, their issues, but they start sharing with you when they see that you are doing the work with passion and interest, and they are getting better. So this man or this young man has been restored with orthodontic treatment. And for the fluorosis in 2 incisors, we had to give him 2 porcelain crowns and a partial denture. And that is how he looked after treatment. So there are many such success stories, not one. So at stage when you are around 13, 14 years, sometimes you have to also take the decision whether you want to go, this case is going to be a case for surgery or orthodontic surgery, or you can do with braces alone, what is called bonded appliance. So I will just show you another case with not well done. This girl came to us from Germany. She's had treated UCLP with not so great outcome on the lip. Had a rudimentary lateral incisor erupting through. So we did a bone graft for her. As you can see in this area, the bone has been grafted and bone is very well organized now. And the rudimentary lateral incisor has erupted. It has a very small, tiny root though. So we did again orthodontic treatment. She went through this whole process of, which takes about 14 months to 2 years from case to case, underwent a revision of the lip, and that's how she looks. She went to study in Thapar as an engineer, and from there she has moved to now Germany, where she is doing her PhD, and you can restore her. So there are ways to restore the aesthetics, function, and self-confidence of a child to live them like normal. Why I'm sharing you these stories are that these are an examples for others as role models, or as in cases that if a child who was an abnormal, had treatment, studied engineering, is married, moves to another country, lives a successful life, then why I cannot? So the first and the foremost thing which actually requires for a healthcare worker, a doctor or a physician or a dentist or a physiotherapist, if he comes across a child with a facial defect, to give him this guidance that please follow a specialist protocol and you can live a normal life. And this picture I'm sharing with you very briefly because of the fact that I received an invitation to attend her marriage, and her mother shared her first birthday video to me, saying that what she was and what she is now, credit goes to you. So credit doesn't come to me. It comes to the science of orthodontics. It comes to the science of health, medical sciences, and I have the medium to implement that. The only thing is that I knew little more about this than others, so I could do more. So when the maxilla is narrow, we like to expand, like I use very often nickel titanium expander, which not everybody uses it. You can bring the maxilla, a small maxilla, a narrow maxilla, to that kind of shape, and then you can restore the arch. And this requires one whole day to explain how nickel titanium expander works and all that. But this is more for a person who is doing it. But to cut it short, you cool the expander, make it a small, fix in the pallet, and from the body heat, this nickel titanium will take the heat and expand the maxilla very slowly, giving it a shape to a normal one. So that's how it works. So maybe in this, I think it is possible to see that. And as you can see in this, that you get a special coolant to cool this part of nickel titanium, which is in the middle part, and it is fixed on the lingual tubes on the maxilla, and then it expands. I will have to, I think, limit myself to number of cases, but this case I certainly wanted to share with you because this girl came to us from Bulandshahr. Again, BCLP, very bad premaxilla, hardly any bone to work on the anterior teeth. We did some innovative biomechanics using half edgewise and half bag appliance, did reverse torquing on the incisors, brought the incisors into place. She underwent a revision on the palate to close the fistula, and that is the outcome. So she has received a number of surgeries, and that's how she looks. And this is the time for her to get married, and she did successfully get married. But sorry to say that it was another.
नमस्कार, टोटल हेल्थ में आप सभी का स्वागत है। मैं हूं संजीव उपाध्याय।
नमस्कार, स्वागत है आपका टोटल हेल्थ में। मैं हूं किरण भारद्वाज। क्लेफ्ट लिप एंड पैलेट यानी कटे होंठ व तालू की समस्या एक जन्मजात विकृति है। आमतौर पर इस अवस्था को एक अभिशाप माना जाता था। इसके बारे में
video is very educative video for cleft patients available on DD News YouTube. I was a British Commonwealth Fellow where I studied the cleft care. And I wish to say that 30 years working on cleft patient has given me a lot of things, including being cited in the British newsletter about my work. And I traveled around the world. I don't want to mention that, but I wish to tell you that this is an area which requires care everywhere. Recently, I was invited in Mexico, and I found that country also needs so much support in comprehensive cleft care as much as our country. So perhaps, except for developed world, the cleft care is still difficult, and in developed world, it is very expensive, except in those countries where the government provides the help. I have almost compiled everything what I did 4 decades in cleft into this book. But I will like to share you with this video which has been shared with the तेरी एक मुस्कान के लिए कुछ भी कर जाऊं मैं, जी तो चाहता है खुद ही तेरा खिलौना बन जाऊं मैं, थाम के हाथ मेरे संग चलता है तू जब कभी, ऐसा लगता है साथ चल रही है मेरी जिंदगी, तू हंसता रहे जिंदगी भर, तुझे लग जाए मेरी उम्र, तू हंसता रहे जिंदगी भर, तुझे. So this information, you can have more information. If you want to scan, you can reach my Instagram and my website. I have a lot of reprints there, a lot of work there, if somebody is interested to know more in detail. And also there is another book which has been recently released in Rajamundry. So thank you very much for your attention on this part. I will take the second part after taking question answer on this, which will be about the facial deformities. Thank you. How much time I have taken?
Yeah, thank you, sir.
Oh,
For the
timing wise, is this fine?
sir. Thank you, sir, for the wonderful presentation. I would say it was very engaging and including videos and like all the case vignettes. Like so, matlab, I have never seen such an engaging presentation, sir. Uh, at times, like it was inspiring all of us. Like me being from a different fraternity. matlab, I'm also curious कि matlab, it can change the lives of patients to such a great extent. Matlab, it's really inspiring, sir. And one of the participant has also requested for the guidance for a fellowship course on for the treatment of cleft lip and palate in the chat box itself.
Yeah, okay. So I'll help him.
Sir, so I request all the participants to kindly write the questions in the chat box, or they can also uh, raise their hand and we can unmute them, and then they can ask the questions. Sir, one question that I had till the time they make up their mind to ask the question, uh, I had a patient, like maybe two patients, sir. Those were of around 40 years of age, and they belong to like remote area of UP, and they had no awareness or no treatment facility available there for the cleft lip and palate. So they suffered due to this illness, and the surgery could be done on a later stage. Like you told, all the interventions before birth till the adolescence.
Yes.
So their bone grafting and those were done, I think, after 20 years maybe.
Maybe.
So they presented very late. So the current issue with the patient, like she presented with some psychological issues, but the main cause was nasality of speech. So in those cases, please guide if they can achieve improvement with the help of speech therapy or maybe other
Yeah.
modalities
Yeah.
though, which are available.
Yeah, so the patients who do not receive surgery in time would have a soft palate which is not fully functional. So the first thing is and if they have sometimes late surgery, they may end up with fistula. And actually, I have not shared those type of patients in this presentation. Maybe at some other opportunity I can share that there was one patient who came to us from very remote in Bihar, and he came to us. He was so shy and he was so introvert. He did not know how to live actually in this society. Anyway, we did his premaxilla was hanging almost down, so we treated his premaxilla and all that. Intruded it with innovation. So I have actually developed because working at AIIMS, I was getting patients from all over India. And these patients come to us with this hope that there is some magic wand here available in AIIMS that doctor will do it like this and I'll become all right. Right. So the first and the foremost thing was to guide them that how to go ahead with the treatment, what effort it requires, how much effort of the parents will be required, how many visits will be required. And now in this, we had to develop protocol so that with minimum number of visits, we could give him the maximum benefit. Right. And similarly, one patient used to come to me from Banaras. She now shares every day the pictures of her family with me because she's married, she has kids and kids are growing. Because when she thought she will never get married. So we evolved these protocols. Some of the protocols I have shown you here are not practicing anywhere in the world, like intrusion of the premaxilla. They don't do with orthodontics. We could intrude and give them a denture. If the same patient was to be in Europe, they will say no. They will first put a rib graft here and there, then put 4 implants and then give a bridge. So it is something like their thought process. They think there cannot be room without carpet, but I can think if the room is clean enough, I can live in a clean room. It is the same kind of approach. So we have to have protocols for the developing worlds. And this is what I advocate in all international forums, that how within those resources, limited resources, making best use of those resources, give the maximum output. So that is one thing, that kind of training is required to change the mindset of our own people, that they should understand what are the protocols applicable to our patients. That is one thing. For example, they say operate at 3 months, 10 weeks. None of our babies are fit to undergo surgery at 10 weeks because they're undernourished. So very few. So most of the Indian plastic surgeons are operating babies not at 3 months, 4 months, 5 months, 6 months, because that is the time when they feel the anesthesia will be safe to them. So similarly, because we are underweight, we are underdeveloped, the nutrition is not there. So the focus on nutrition, on prevention of respiratory infection is required during the early ages. With respect to your particular question, I wish to say that in patients, if they have nasality, so we have to know the reason of nasality of speech. And quite often the cause of nasality of the speech is the hole in the palate of the fistula. So it is not necessary we close the fistula by surgery. We can close the fistula with an obturator. And within this obturator, we sometimes built up an extension which goes into the soft palate, which serves as an speech bulb, which gives the velopharyngeal seal. So this person can be significantly affected or helped with the nasality of speech by prosthetic devices.
Right, sir. Right, sir. Thank you very much, sir.
Yeah.
Right, sir. So there are another questions which are posted other than praises for the session. Dr. Dipashri sir, she asked, so sir, we have seen successful cases, but what visit your cadaver field? Dr. Dipashri, can you please unmute yourself, because we are unable to read it.
She can speak.
You can speak, ma'am.
Yes, sir. The presentation is very nice, very, very nice. We have seen so many successful cases and you have presented it very nicely. But in our college, we have seen so many unsuccessful cases with palatal fistula, and also the life after that was miserable, repeated infection, how they can be socially just accepted. Please advise, or please just highlight some
You are from
points.
which college you are from, ma'am?
RGKR Medical College, Kolkata.
Kolkata. Kolkata, I have been visiting one hospital in Kolkata as an advisor to the cleft center. I will not name the hospital and the center because I am advisor with ABMSS. And I was really very, very disturbed to see the some of the cases which were not in good shape. And there are a couple of things I wish to add. The first and the foremost thing was that in none of the patients' oral hygiene, dentist advised them to maintain oral hygiene. So they had a very poor oral hygiene, halitosis, periodontal disease, which can be done by any dentist. You don't need an orthodontic specialist or super specialist to do that. So it started with that. So too much of caries, abscesses, gum diseases, and periodontal disease. The second thing was now coming to the cleft deformity. So I think highest number of BCLP cases, if I have seen in my life, in one center was in Calcutta. And in many of these patients, I'm sorry to say, they had undergone premaxillary osteotomy. And when I raised this issue there, I was told that earlier they were doing, now they are not doing, but I think they are still doing. Why a plastic surgeon will do premaxillary osteotomy? He will do it only when there is nobody to help him to retract the premaxilla. If you as an orthodontist can help him to intrude and retract the premaxilla, he will not do it. That is the another thing. Now the third thing is that the mutilated malocclusion need not to be an ideal outcome, all these situations. That is what I was trying to convey. If you are able to achieve an profile and occlusion which is acceptable, not the textbook acceptable, then you should be happy. You should be able to help. The next thing is that in most of the cleft patients, it is the charity work. I could do charity work because I could afford to do charity, being a government employee. I did free of cost. I was doing patients free of cost. But still in those free of cost treatment, I found ways to help them with the minimum number of visits. That's what I'm trying to say. Okay. Don't always think of a bridge and implant. In 3 cases I have shown you, they are using a a partial denture, come prosthesis, come obturator, come speech therapy, speech appliance. So in one go, you could rehabilitate, you could restore, you could correct the speech. So each case in cleft requires a thoughtful approach. No two cases are similar. No two situations are similar. No two malocclusions are similar. And no two approach is similar. So for every child, you have to think differently how you can help. So if you need any assistance from me, you can please share your records. My email is there. You can share on my website. I have been advising to people all across treatment planning, and I can also help you with treatment planning. I have no problem.
Sir, one question, whether the anesthesiologist has some role during perioperative period for the success of this surgery? Whether the anesthesiologist, yes, during perioperative period, whether they have some role.
Perioperative, yes, why not?
Yes.
Because perioperative period is an ICU time. Right. So he has to see that the patient is breathing well. There is no obstruction. Yeah. So all that.
Sir, any post-operative advice from our end which you think is very important? Please tell us.
There are protocols which has been created for peri-operative time after the cleft surgery. So now, is it a case of cleft lip, cleft lip and alveolus, UCLP or BCLP? Number one.
Okay.
Then what approach has been used? If it is a lip and alveolus, there is nothing much to worry about. If it is UCLP complete, then it depends. Surgeon has used what technique. Sometimes they use only lip repair with Millard. Sometimes they do Millard with Vomar cleft. Sometimes they do Millard, Vomar and gingivoperioplasty.
Yes.
So the surgeon, you have to interact with surgeon very closely, and you have to understand his words, his jargon of words, and he should understand your jargon of words. Please understand this, because the gold standard of cleft care is considered Oslo, Norway, Copenhagen, Scandinavia. Why? Because in whole of Norway, there are only 2 centers for cleft. Any child with cleft, once registered in Bergen or in Oslo, will get all his treatment life all till adulthood.
Okay.
The same surgeon, the same orthodontist, the same dentist. Now what is happening? They come to me, I ask them 5 x-rays. Then he loses those x-rays, go to another dentist, another orthodontist, he writes him another 3 x-rays. By the time the patient used to come to me in NAMS, he used to have 50 x-rays, but nobody has done anything. He has been only exposed to radiation. I'm sorry to say this. So before you prescribe any procedure, or call the patient, are you going to use that patient's time efficiently for that visit? Why patient get discouraged? Because they say they go, nothing happens, they come back.
Yes.
Unless you prove them that you are doing something for them, they will not come. Because they don't have to only come to a doctor. They have to go to study. They have to earn their money. Many of them are poor. If they come, they lose their time. That is the lost man hours I explained to you in the beginning. So this is, cleft care is not just a medical issue. It is a social issue. It is an issue related to health economics. It is related to logistics. It is an issue related to the society where he works. So many things are linked. So if you are interested in cleft care, then you have to think holistically in totality. And you have to have your friend as an oral surgeon. You have to have your friend as a plastic surgeon. Plastic surgeon should understand you, what you can do for him. He will respect you only if you can show him something what you can do for him. Otherwise, he will say, you are a dental doctor, I don't need you. So you have to create your own space to prove him that, well, I have raised the dome. I have created the closure of the space. The day I give the plate, the child is smiling. Before that, he was not able to breathe. Till you prove him that you have done this, why should he call you?
Yes.
And the other thing is about cleft care, I wish to tell you, still there is a ignorance, not at your level or my level. It is ignorance at all level, social, political, or even politically, we could be able to dig through the RBSK. So that's very good, has happened. Very good thing has happened that no cleft child now remains unattended, at least RBSK records it. But before that, you know what was happening, you know. So it requires a kind of social revolution, you know, ma'am. It is not just the
Yes, sir.
hospital, you need medical care. So you are based in Calcutta.
Yes, sir.
So which hospital you work, ma'am?
Sir, previously I was posted in SSKM hospital, now in Arjikar Medical College.
Acha, you work with the government, is it?
Yes.
RGKR Medical College. So you have a cleft unit there, and become
Yes.
them. Invite them
Yes.
over a cup of tea. Give them what you can do. Learn what they can do for you. Go to their
Okay.
clinics. I helped to make a cleft unit in Rohtak. Similarly, I made to help cleft unit in Ramaiya. So you have to create a unit. You have to, and do it
Thank you,
regularly.
sir.
Blessings will come to you. I want to tell you, they have come to
Thank
me in
you.
many different ways. You know.
Thank you so much, sir.
Yeah. I have treated poorest of poor, richest of rich, the most important man of the country. But what blessings I got, that will only come once you start helping these poor.
Thank
Thank you,
I
sir.
think it has become more of a political.
No, sir. Yeah. No, sir. It's very helpful because, like, as you emphasized, in any unit, and for such complex issues, I think that multidisciplinary teamwork is needed, and that
Because
building team
see,
is
surgeons
right,
are too busy.
right,
They don't care
right,
left
sir.
and right. They operate and go away. Now
Right,
you
sir.
have to see, because the problem you have to face. Surgeon will go away after operation.
Right,
Maxillary hyperplasia will happen.
Right, sir.
Caries will happen. Magla will collapse. Speech will be difficult. So then you have to have friendship with him and
Right,
guide
sir,
him
right.
what kind of surgery to do, which
Right.
causes minimum distortion, minimum this,
Sir.
follow up. You know, so many things. You know, it is not just one thing.
Right, sir. So for the optimum teamwork, sir, you have guided the better way. So it will definitely help our participants. Another question, I think, sir, in the similar line, they have asked that one plastic surgeon asked them to correct a rotated and displaced premaxilla in a 5-year-old kid.
Yeah, very
So,
easy, very
yeah.
easy. Just use bonnet cup appliance. Make it with room cure, room temperature cure silicone. You can read my article in Cleft Palate Journal. Go to my website. That article is also there. It is in American Cleft Palate Journal. Very simple way of doing it. I have shown the one case example, but you can use the same.
Right, sir. Thank you, sir. So if there is any doubt, you can still raise your hand. Yeah, another one question. Even in 5 years, sir. Yeah. So sir told that, yeah, in 5 year,
We can centralize the premaxilla.
Yeah, that can be
Or
done.
you can also use fixed appliance depending upon if there is an anchorage there. Then use open coil spring on one side, and you can centralize the premaxilla. It can be done very well. I showed one case actually. In the beginning, the second case was the off-center premaxilla centralized using fixed appliance.
Right, sir. So thank you very much, sir, for the interesting discussion. So I think if there are no more questions, so we can move to the next part of the session.
I have made that lecture little smaller than this one. So I will now start that because it is more of an introductory lecture. Here I am. जरा इसको थोड़ा हेल्प कर दीजिए. ये है ना, बंद हो गया क्या? नहीं है, sorry. हाँ, I got it. I share. शेयर नहीं, मैं लेक्चर देख रहा हूँ कौन सा है. फाइल तो खुली हुई है वैसे. हाँ, ये full screen. The part will be an introduction to the specialty of orthodontics. You have seen some of the things which an orthodontist can do in cleft care, but this will be just giving you an overview of the what is malocclusion versus normal occlusion, how the teeth develop, grow, how the face grows, and how the things evolve in normal face. So at about 2.5 to 3 years, usually you have all the baby teeth in mouth, what is called deciduous teeth, and they are 20. Now, quite often we give them less importance because we think they are milk teeth. But I think they are very, very important part. Nature has not made anything rudimentary. There is some reason God has done that. Now, these baby teeth or the milk teeth, they help the baby to masticate. So he converts from liquid diet to semi-solid to solid diet, which is
बहुत इनकी
essential.
बात है फारूक की इधर की उधर बातें बनाने की। कुछ सरब का भी बोलने लगे तब मैंने कहा कि फारूक हम इंटरेस्टेड भी नहीं है सुनने में। वही सरब की थोड़ी आदत है ना, ज्यादा बोलता है, हम ऐसा रिपोर्ट कर देंगे, हम वैसा। मैंने कहा फारूक देखिए।
डॉक्टर रूबी, कैन यू प्लीज माइक को बंद कर लीजिए, हम आपकी सारी बातें फारूक के बारे में सुन रहे हैं, तो उसको बंद कर दिया आपने, कर दिया, अच्छा। So that is the mastication. But why mastication is essential just only for nutrition and growth or something else? It is essential for the growth of the jaws. The alveolar growth, because baby teeth are small, jaws are small. So the mastication gives stimulus for the normal growth of the face. And all permanent teeth have bigger size than the baby teeth. For example, a lower incisor or upper central incisor is almost 1.5 times of the size of this. From where the space will come if the jaws don't grow? The permanent teeth, there is in the bottom of every baby tooth, there is a permanent teeth. So he's like a pole to guide the tooth where to come, which is its normal place to come. So it has many roles. So when you have the normal occlusion, the permanent teeth, so usually there the midline is coinciding, as you can see that. So there is a central, lateral, and canine, 2 premolars, molars, and these molars meet to the upper molars, meet to the lower molars with the mesobuccal cusp here and here. We call it the buccal groove. And the class 1 canine relationship is when the distal of canine is to the mesial of canine, as you can see on this side, both sides. And the 4 incisors are housed in an area, lower incisors, which is less than the upper 4 incisors, so that the canines can be accommodated. So this is the natural arrangement of teeth. So now, if the baby tooth is lost prematurely, you would understand that the guidance to the permanent tooth is gone. Something also very important here is that this baby deciduous molar, second molar, or on the baby molars, they become a kind of a landmark for the permanent molar to come. If this is lost prematurely, the permanent molar will come forward and the arrangement of the arch is disturbed. Sometimes the permanent erupt lingually, and this simply is showing that there is not enough space in the lower alveolus to grow. Some other times, the lower incisors may erupt anterior to the uppers, like in this case. Normally, the maxillary incisors are out, which we call it buccal overjet or labial overjet. And they may also be off-center, lower incisor. We call this as a functional shift. Now, this functional shift is not that uncommon. It is pretty common. Only thing is you should be able to detect it in time. And if detected in time, you can correct the functional shift and the child will grow as normal face. But if not corrected, this will keep on aggravating till a facial deformity occurs and the person may have a face with jaw on one side. So that is called deviated lower jaw. So for this son, this boy was a class 3 situation. Midlines are off. There is a lateral functional shift. And this is shown that if the child is asked to open the mouth, bite normally, edge to edge, the shift can be corrected. So that is the indication. So it is a functional, not skeletal origin. And you give him some kind of an appliance which is beyond the scope of discussion on this, and you can correct with this. So for rest of the life, he will grow as normal child. Otherwise, he would have become a child with an abnormal face. So this is the message I wish to give, that there is a need to have early intervention in the children, and the pediatric surgeons usually help to restore caries and detect these kind of situations. Thumb sucking beyond 4 years, something like this will lead to open bite, and that is also a situation which is not good. Now, some children develop recurrent infection in the throat, tonsillitis, throat infections, and they become mouth breather. So when they become mouth breather, their face does grow like adenoid faces. We have all known that. Their maxilla is small. So what you want to do with them? You want to expand their maxilla. You help them to breathe. So that is the detection of obstructive sleep apnea in children at young age. So all snorer, all children who are developing faces like adenoid faces should be attended as early as possible. And sometimes you need the interference from ENT surgeon and orthodontist together. So this child has been treated with maxillary expansion, has become a normal faces person, and obviously he will grow normally. So he has been also corrected with obstructive sleep apnea. And which you can see that now how we analyze that how narrow is the on 3D volumetric imaging, that this nasopharyngeal space is very narrow, and here it is bigger, which is normal. So that was his arch, a very narrow maxilla, crowding. We did the maxillary expansion with an expander. And actually he also has a transposed premolar actually. If you see here that premolar is here, canine is here. So we maintained that, and we created an occlusion which was good for him. Quite often we have children where the one incisor is not coming, and if you take the history, you will find that the baby had a trauma during childhood, which is not uncommon. Tooth had become black, tooth has been taken out, non-vital tooth, and the permanent incisor has not erupted, as in this case. So you see a bulge. You see a bulge here. You see a bulge here. So when we take the CT in this case, we found that he has an incisor which is very high placed in Torozo version, and with the CBCT you can locate the exact location and relationship. So we decided to expose the tooth surgically. Before that, we have this kind of appliance in place, which I call welcome preparation for the tooth. You can read my orthodontic book to know what is the welcome preparation, how you prepare the anchorage for such teeth, and how you derotate these teeth is using nickel titanium spring, which is also kind of my innovation. You use a twin springs, one on the labial, one on the buccal side, activate them to twist the incisor. When it erupts through, as in this case here, then you ligate with nickel titanium wire and he develops a normal occlusion. So timely intervention, recognition of the problem is key to successful outcome. This young girl had come to me with very gummy smile, as you can see on the left side, and she was almost advised the premaxillary osteotomy for intrusion. However, I could manage it with the same intrusion mechanism which I use in cleft patients actually, by Ricketts intrusion arch, TMA wire, and you can see the outcome. Here she is on your right. So you can help many different ways. She's a different person now. She moved to Canada. She's now again back in India, and I think I'm seeing her next week. So that was the pre-treatment and significant 100% debite, and then after treatment. So you have these, if these children like the one you saw before is not treated, adenoid faces, they may become very severe class 2 like this. So they have a very idiotic look, severe class 2, and then these patients would require surgical intervention. They will not get treated with the orthodontic alone, but class 2 DIV2 you can manage somehow. This is again a late reporter girl, class 2 DIV1, small maxilla, a small mandible, large overjet, and we use the functional appliance therapy, which very few people use. Those days when we started in AIIMS, actually in 1990 we started using twin block appliance. After I had a long work with William Clark, the inventor, and these are the patients from the beginning, actually, those days, early days. And this particular girl was so shy, introvert, suffered from psychological issues, deep bite, had trauma on the incisors. After this became I think, a very famous drama girl in that school. So that is the change in life. Yeah, so this gentleman, again, this is adult actually, and who needed again help with the surgery, with the orthodontics, but he decided he doesn't want orthodontic surgery, so we treated it with the implants, and using implants and retraction of the maxilla, as you can see, we could help him to get the normal profile. So you can see in the X-ray how much retraction we could do with only in the upper arch extraction, lower arch non-extraction. These lines are coming from where? I don't know. It's coming in. My God! So can we request that participant to remove these lines? There are 3 lines coming in every slide. So, हाँ मेरा marker on है क्या? देखो ये 3 लाइन सब पूरी हर स्लाइड में आ रही है, तो यहीं पर आ रही है। मैं सोचा था मेरे से कुछ गलती हुई।
It's 4:30.
ये देखो। अरे यार ये तो बड़ा यार, मैं तो। So my humble request, please do not keep the pictures of any of the patients for ethical reasons. My humble request to you. If you want anything from me, you just let me know, I will share with you. Okay? So, so that is how this gentleman is. So we, नहीं ये मेरी स्क्रीन पर ही है यहाँ पर। स्टिल जूम में ही है। अच्छा अच्छा, जूम में ही है ये स्लाइड। अच्छा अच्छा, कहाँ जाना है? प्रेजेंटेशन। थैंक यू श्रीवास्तव जी, तभी तो हम आपके बिना हमारा काम नहीं चलता है। हाँ। अच्छा, कौन ड्रॉ कर रहा है लाइन? पार्टिसिपेंट्स लाइन ड्रॉ कर लेते हैं। अच्छा, कोई बात। तो ठीक है। So here you see the change in the profile and the personality of a person. So similar type of situations where you can help the people to have. Now, there is one question asked: is it only aesthetics? No, it is beyond aesthetics, because longevity of dentition is important. Prevention of caries is important. Susceptibility to periodontal disease is important. So the teeth which are crowded, abnormally placed, they are more susceptible to periodontal disease. They are more prone to dental caries and early loss. So at present, what is more important is quality of life. Now, this lady which you see on the left, she came to me in, I think, 2004. And she was treated in some hospital in Delhi, and she had a traumatic bite, severe periodontal disease for occlusal trauma. So she will go to dentist will grind the teeth, and go to again grind the teeth. Then she came to me. I had just started using self-ligation bracket. My first case of self-ligation in any adult patients, actually. She was that time about 45. I don't know how old is she now. Yeah, 65 must be. So then we used the self-ligation, and we could help her. And she has been on my constant follow-up every year, actually. So adult patients can also be helped. Closure of the diastema, retraction, and maintenance of the teeth. Otherwise, she would have lost all her anteriors by now, both upper and lower, and would have on a denture. So this is a very interesting boy who came to us from Muzaffarnagar. And his mother told me that his engagement has been cancelled because he's a very severe snorer. He's engaged to his cousin who lives next door, and he snores so much that even the padosi ut jate hain. Neighbors even get up, you know. And he was snorer simply because of the fact that he had a very small mandible. And he was a case of temporomandibular joint ankylosis, which was treated at AIIMS by Dr. Chaudhary, one of my colleagues. He will be taking lectures next week, actually, in the next session. Actually, I have brought him in to discuss with you. Don't miss his lectures. So, very narrow maxilla, and we decided that we should bring his mandible forward, do distraction so that the retropharyngeal space, which is collapsed because of the small mandible, is taken care. So I expanded the maxilla, aligned with incisor extraction, which is rarely done, but in this case, I had to compromise that kind of thing. He underwent distraction osteogenesis of the mandible. And after distraction osteogenesis, as you can see, that his nasopharyngeal airway, how it has improved from a very narrow space to this much, to this much, to this much. So that's the progression that happened with distraction. And that is how he was in 2017. Since then, he is my friend. He will keep on sending me messages because he is married, he has 2 kids, and he is healthy. So for such situations, earlier we were able to manage with 2D, but now very often we like to do 3D planning. And we like to superimpose the intraoral scanning with 3D photographs with CBCT images. It is now something not new. It is quite common now. And for this, we have evolved 3D diagnosis, automation in 3D diagnosis. So this is an example where how we were using the training the computer. Like people are talking about AI now, but we have this patent 5 years ago to how to train the computer on 3D diagnosis. As you can see in this case, we could our computer was trained to do the algorithm to do all these landmarks, detection of landmarks using algorithm, and then create templates for all those measurements which were needed. But this one, the one which I'm showing you now is the volumetric imaging of the sinuses, which was done effectively. So both these they were published in Sciences, Computer Sciences Journal, and few of the landmark articles are published also in AGODO. So you can go to my website. I have divided my website publications into subject-wise and year-wise. So if you go subject-wise in 3D imaging, you can see the list of all articles which are based on the subject-wise. So this case again treated at AIIMS, severe class 2, but why I'm showing you this case was because of the 3D planning. 3D planning is done, and then you could simulate, then you can create the template, and on that 3D printed models, you could even get the 3D guides. So 3D guides, 3D plates, everything is done online, and then you could obviously do the surgery through these plates. So there are different ways, different methods to treat facial deformities, and the current concept involves a total 3D planning. I'm happy to, this subject is very wide, very, very vast. I have 2-volume book on it, as you know that, 3,000 pages book, but it's not possible to cover everything, but I have given you glimpses of in what areas the medical specialties should not miss recognizing the dental aspect, the orthodontic aspect. That was the whole idea, to sensitize you with this. And to my dental people, the idea was to let you know what all I am doing. Most of you already know, but nevertheless, there is a scope to talk more and chat more. I like to again thank you for your time and patience and joining this session. Is there anything more you want to do?
Yeah, thank you, sir, for covering. Despite the topic was very vast, but still you have covered, you have like covered majority of the topics, and I think Dr. Kumar Anand, he was also there in the last session. So he has raised his hand. You can just unmute yourself and you can ask Dr. Anand.
He would have some patient with him.
Good afternoon, sir. Good afternoon to all
How are you,
respected senior.
Anand?
Sir, fine, sir. Very good, sir. And सारे lectures आपके सुनता हूँ, sir. And
when I see you, I feel very happy that there is someone who
sir,
is
same year also, sir.
so
Same year.
attentive and careful. And
Yes,
also
sir.
talking about clinical real life issues. You always bring
Yes,
out
sir.
real life problem, how to solve it.
Sir, it is good to hear the responsibility, what you said, that when a patient turns to you, how should we be responsible, sir? It is अच्छा लगा सर आपका सुन के कि कैसे काम करना चाहिए, and इसीलिए सर आप आज वहाँ हैं भी. सर एक क्वेश्चन था सर, जस्ट वांटेड टू आस्क सर, जो क्लेफ्ट लिप पैलेट में जितने भी केसेस आपने दिखाए, प्रिवेंटिव मेजर्स सर क्या हो सकता है सर?
प्रिवेंटिव मेजर्स जो है ना, 2-3 है. देखिए, सबसे पहले तो ये है कि alcohol and smoking for any woman who is likely to be mother, not who has become pregnant, likely to be mother. उसका रीजन ये है कि जो फेस का डेवलपमेंट है वो तो शुरू के 8 या 10 हफ्ते में हो जाता है. और जब एक लेडी मतलब आफ्टर दी शी मिसेस हर फर्स्ट मेंसेस, उसके बाद जब तक वो चेक करती है और जाती है 6-7 हफ्ते हो जाते हैं, तब उसको पता चलता है वो प्रेग्नेंट है. तब तक फेस फॉर्म हो चुका है. तो जो टॉक्सिसिटी इफेक्ट हैं ड्यू टू अल्कोहल एंड स्मोकिंग, दे हैव ऑलरेडी एक्टेड. सो अगर किसी लड़की को मदर बनने की इच्छा है, अगर या उस लाइफ के उस फेज में है, तो उसको स्मोकिंग और अल्कोहल को त्याग करना पड़ेगा. हिंदी में तो यही बोलेंगे. और मैं तो बैंगलोर में रहा हूँ इतने साल, और मैंने वहाँ जो सिचुएशन देखी है, मैं तो रम्मा यूनिवर्सिटी में प्रो वाइस चांसलर था. हमारे बच्चे को देखता था, पर हम कह कुछ नहीं सकते. हम क्या कह सकते हैं? क्योंकि जब मैं वहां से अपने वॉक करके रात को लेट घर जाता था, बच्चे लोग तो ऑलरेडी सिगरेट की दुकान पर खड़े होते थे. तो हम क्या कह सकते हैं? कुछ नहीं कह सकते. आप सिर्फ चले जाते हो चुपचाप सिर नीचा करके. तो सिर्फ इतनी सी बात है, पहली बात. दूसरी बात जो है न्यूट्रिशन. न्यूट्रिशन में फोलिक एसिड को बहुत ज्यादा यूजफुल माना गया है. Folic acid not in normal doses, 4 times of the doses. If any woman is thinking of going to pregnancy, she should be taking folic acid almost 4 times the daily requirement. ठीक है. फोलिक एसिड का जो क्लेफ्ट के प्रिवेंशन में असर है वो डिबेटेबल है अभी भी, इसलिए नेशनल पॉलिसी उस पर नहीं है. बट कुछ कंट्रीज ने यूज किया है, जैसे टोलारोवा की स्टडीज हैं जो अभी तो मदर मानी जाती है, मदर ऑफ क्लेफ्ट प्रिवेंशन मानी जाती है. अगर आप कभी मदर ऑफ क्लेफ्ट प्रिवेंशन डालोगे, टोलारोवा का ही नाम आएगा, मारिया टोलारोवा. शी इज अ पॉलिश लेडी, बट मूव टू यूएस. ठीक है. तो उसकी पीएचडी इसी में थी, उसे भी जिंदगी भर काम किया उसने. तो जो फॉलिक एसिड का प्रिवेंशन इन न्यूरल ट्यूब डिफेक्ट, एंटी-डी में तो प्रूवन हो गया है, प्रूवन है. इसमें है या नहीं है नहीं मालूम, पर फिर भी लोग करते हैं, फायदा होता है. तीसरी चीज ये है काउंसलिंग. अभी मेरे पास आई हैव ए स्मॉल बेबी विद क्लेफ्ट. अब उनकी फैमिली में ऑलरेडी 2 क्लेफ्ट हैं, फिर तीसरा बेबी क्यों करना? भाई 2 में खुश हो लो.
यस सर.
दिस इज अ पर्सनल चॉइस, आई एम नॉट टू कमेंट, बट इट इज समथिंग ए सोशल इशू. सो काउंसलिंग बहुत जरूरी है. फिर which cleft patient should marry whom? Cleft and cleft should not marry. The chances of having another, तो उसके लिए जेनेटिक काउंसलिंग वाले हेल्प करते हैं आपको. कितने चांसेस हैं आपके, वो आपकी 3 जनरेशन की 5 जनरेशन की पहले हिस्ट्री लेते हैं. हिस्ट्री के बेस पे वो प्रिडिक्शन करते हैं कि भाई आपके, अगर आप शादी करोगे नॉन क्लेफ्ट से करोगे, आप क्लेफ्ट हो, तो आपके चांसेस आगे ऑफस्प्रिंग में क्लेफ्ट होने कितने हैं. दिस इज अ वेरी पर्टिनेंट क्वेश्चन व्हिच एवरी क्लेफ्ट पर्सन आस्क बिफोर मैरिज और समटाइम्स आफ्टर मैरिज.
सर एक क्वेश्चन और है सर. सर व्हाट अबाउट द अडल्ट पेशेंट सर? मेरे पास 2 केस आए हैं टिल डेट सर. मतलब
ट्रीट किया 25 साल 30 साल 35 साल वाले सब ट्रीट किए हैं भैया.
सर लेकिन
वही आता था, वही आते थे, बाकी जो मक्खन था वो तो कहीं और चला जाता था। तो बाकी जो जो मोस्ट कॉम्प्लेक्स सिचुएशन थी, मैं अपनी कोई हैंडल करता रहा जिंदगी भर,
यस
स्ट्रगल
सर,
करता रहा उनके साथ। हाँ, तो वो उस तरह मुश्किल नहीं होते जितना आपको लगता है, इतना मुश्किल नहीं होते, उसमें अनयूजुअल एक्सट्रैक्शन सोचने पड़ते हैं।
ओके
अभी सेकंड प्रीमोलर पैलेट में पढ़ा है, उसके लिए हिचकिचाओ मत, मैकेनिक्स सिंपल करो, टाइम सिंपल करो, एफर्ट सिंपल करो, ये है। पैलेटली प्लेस प्रीमोलर है, जरूरी नहीं उनको खींच के आर्ट्स में ही लाना है, उसको निकालो, 4 को पीछे ले जाओ, 3 को पीछे ले जाओ, इसको बोलते हैं हम कंसोलिडेशन ऑफ इडेंचुलस स्पेस, ताकि जो पार्शियल डेंचर बने सारे दांत उसी हिस्से में ही लगे,
ओके प्लीज।
पार्शियल डेंचर ना बने। एक केस हमारे पास नया जन, सॉरी आई नीड नॉट से दैट नेम, उसका हमने क्या किया, उसका सेकंड प्रीमोलर नहीं था, फर्स्ट मोलर को पीछे लगे, कैनाइन को उसकी जगह ले गए, सारे सेंट्रल इंसाइजर राइट में शिफ्ट कर दिए, एक दूसरा पेशेंट था, सारा इडेंचुलर स्पेस एक जगह कंसोलिडेट करके उसको पार्शियल डेंचर दे दिया, आज तक वो पार्शियल डेंचर वही पहन रही है वो लड़की, कब दिया होगा मैंने।
सर आई हैव द फोटोग्राफ, मैं आपसे शेयर करूंगा सर आपको मेल
और
पे सर।
अपने केस का सारा ट्रीटमेंट प्लानिंग आपको करनी है, वो
जी
आप
सर।
है ना, वो प्रोस्टोडोंटिस्ट करेगा, वो एस्थेटिक वाला आएगा, वो कोई कुछ नहीं
नहीं
करेगा,
नहीं।
आपका बेबी है, आपने ही संभालना है। मैं खुद बनाता था, मैं अपने पेशेंट्स का पार्शियल डेंचर भी खुद, उसकी वैक्सिंग करके, खुद देख के, उसकी नेक को टॉर्किंग करके, नेक दबा के, उनको टॉर्क पता नहीं होती, उन्हें नहीं मालूम व्हाट इज लेबियल टॉर्क, व्हाट इज लिंगुअल, वो सब करने के बाद ही फिर उसकी आगे दिया, तो फिर लगाया।
यस।
तो ये इसमें इसमें थोड़ा सा इन्वॉल्वमेंट चाहिए, कुछ भी अच्छा करना है, मतलब अगर आपने अपने घर को भी ठीक करना है, आप घर बनाया, अगर आपने बेडरूम बनाया अपना अच्छा बनाना, तो आपको इन्वॉल्वमेंट होता है ना, मैं यहाँ टेबल रखूंगा, ये वही चीज है।
ओके
मोर यू आर इन्वॉल्व बेटर इट इज। पेशेंट सेंट्रिक होना चाहिए, ये नहीं कि ऐसा ही होगा, ऐसा नहीं, पेशेंट क्या अफोर्ड कर सकता है, नहीं कर सकता, आ सकता नहीं आ सकता, भैया जो महीने में 2 बार नहीं आ सकता, उसको एक बार के हिसाब से उसकी मैकेनिक्स लगाओ, वो वाली वायर चूज करो जो 2-3 महीने में आ जाए तो भी काम चल जाए।
ओके सर।
तो बायोमैकेनिक्स को पेशेंट की रिक्वायरमेंट के हिसाब से मॉडिफाई करना पड़ता
सर एक क्वेश्चन और है सर। सर साइकोलॉजिकली सर जैसे इन डे टू डे सर लाइफ सर, अब तो सर अल्ट्रासाउंड बहुत कॉमन हो चुके हैं सर।
है।
तो जो प्रेग्नेंट वुमेन जो है जिनको ये अर्ली डिटेक्ट हो जाता है सर,
अच्छा, वो
तो
कब तक अबॉर्ट कर सकते हैं, ये क्वेश्चन है ना, वो भारत सरकार के नियम के हिसाब से होगा। उसका एक नियम है कि कितने हफ्ते तक आप कर सकते हो, वो अभी कुछ चेंज हुआ है ना उसमें,
22 वीक्स।
22 वीक्स, हाँ इनको मालूम है, 22 वीक्स तक कर सकते हो आप, पर उसमें
ओके
शायद, हाँ, तो कुछ लोग करते हैं, मुझे नहीं मालूम, नहीं करते, पर बट जो लीगल उसका सिचुएशन ये है कि 22 हफ्ते।
यस सर।
अगर
ठीक।
सिंड्रोमिक होते हैं तो वो लोग कर लेते हैं, मल्टीपल कंजेनाइटल डिफेक्ट्स होते हैं बहुत से बच्चों में,
जी जी
हार्ट
जी
भी है,
सर।
जिनेटाइलिया भी है, क्लेफ्ट भी है, वो सिंड्रोमिक है। नॉन सिंड्रोमिक के मोस्टली लोग तो नहीं करते, जो मतलब मेरी नॉलेज में।
ओके थैंक यू सर। थैंक थैंक यू फॉर द आंसर सर।
मोस्ट वेलकम। कहाँ तुम पटना में हो?
सर रहने वाले पटना के, बट अभी असिस्टेंट प्रोफेसर हैं सर माता गुजरी मेमोरियल मेडिकल कॉलेज में सर।
ये कहाँ पर है?
किशनगंज में है सर, चिकन नेक के पास सर।
अच्छा, तुम वहां पहुंच गए हो। अच्छा
सर वाइफ भी यहीं पे है ना।
अच्छा अच्छा, चलो ठीक है, ठीक है, कभी आएंगे तो आएंगे
यस
इंशाल्लाह।
सर, श्योर सर, श्योर श्योर सर, श्योर सर, मोस्ट वेलकम सर।
Thank you, Dr. Anand.
थैंक यू सर।
The active participation and for asking questions.
Yeah,
So,
relevant,
yeah,
very
right.
relevant.
Very relevant questions, sir.
Thank you,
It
sir.
attracted interest of, I think, other participants who chose to be muted. So I again, I request and I encourage other participants. They can also just raise their hand, or they can just unmute themselves and they can ask the questions. And they can utilize this opportunity because we have with us eminent speaker and expert. So Dr. Yashashvi, no, sorry, this was the mouse cursor. So if anyone else want to ask, they can just ask anything. Yeah. Dr. Yashashvi, do you want to ask? Since you have unmuted yourself. No. Okay. So if there are no more questions, then we can close this session? Like we can move towards the closer. Okay. So I again thank Professor Kharbanda sir for the interactive and this amazing session. And now I request Professor A.K. Sood sir, the Deputy Secretary of National Academy of Medical Sciences, for the vote of thanks. Sir, over to you.
Thank you, Dr. Jaswant. Again, it was a very nice presentation, and I think all of us have gained a lot of knowledge about this cleft lip management, and especially sir has discussed the preventive and comprehensive approach. So thank you so much, sir, for sharing your experiences of several decades with all of us. I'm sure the practical tips which you have given will be very useful, especially for the practicing dentists and the students who have attended this session. And we look forward for your support in future also. I also take this opportunity to thank all the participants, especially the faculty members who have joined us, as well as the PG student. And once again, I would like to say it is your own program. And if you want to come forward to take sessions, you can suggest topics as well as you can be a part of it as a resource person. For the information of the PG students, and the next session which we have is on 6th of March. And there again, we are going to have a very interesting topic where Dr. Deepika Mishra from Center for Dental, yes, sir, Dental Education and Research.
That's a very nice topic.
Yeah,
AI is
she is going to cover how AI and digital technologies can be used for the diagnosis of precancerous condition of the oral cavity. So I request you, if you have any question, you can send us in advance and we can share this question with the speaker. For the information of the participant, again, we have shared in the chat box, especially for the PG student, we have in collaboration with the ICMR, we have biostatistical helpline. And if you have any issue related to your thesis work or your research proposal, expert from National Academy as well as the ICMR will be happy to help you. It is online helpline and you can always register in that. Another information is related to a 12-week online program which we have on artificial intelligence for healthcare in collaboration with the IIIT Hyderabad. Currently, the third batch is going on and the registration for the fourth batch is continually open. And if you want to join that, you can look into the website of National Academy as well as of the IIIT Hyderabad. Once again, I would like to thank Dr. Jaswant for moderating this session. We are grateful to you for your support. Here in the National Academy, Mr. Ravi and Mr. Shivam has been helping us for organizing these sessions, writing to you, as well as ensuring that these sessions are telecast on the Zoom. And all these recordings are available on the Zoom and YouTube. You can always refer to that. So once again, I thank you all for being with us and making this session very, very interactive. Thank you, sir. Over to you, Dr. Jaswant, for closures.
Thank you very much, sir, for the word of thanks. And I think with your permission, we can mark the closure of the session. Thank you, sir.